want to go from that to move on to now getting a little bit more narrowly in terms of targeting treatments to specific patients. So we've talked a lot about, sort of team-based care, but, as we look at the evidence and we look at sort of new therapeutic treatments that have come out, taking a patient-centered approach in diabetes care means looking at many available treatment options, what I would call the alphabet soup, the SGLT2s and the TDZs and so forth and so on. And I guess the question is, sort of, well, we might start with metformin. How do we know where to go from there? Sort of, how does a physician, how does a provider approach that decision?
Well, I think we all probably have different ways that we sort of approach this. I think one of the challenges is there aren't large studies that say with somebody on metformin, what's the best next agent to go to? And so we really have to base our decisions on the fact that each of the medicines work in different ways. They have added benefits beyond just glucose control, whether that's weight loss, less hypoglycemia. And ultimately, it's a negotiation and a shared decision process with patients of what's most important to them. Is the cost of the medicine? Is it weight loss? Is it the risk of hypoglycemia? And based on that and their comorbidities, choosing the right agent.
And I think I'd add two more factors, which would be, one, the presentation of the patient at the time of diagnosis. Some diabetics, again, are very symptomatic and severe, such that an oral agent at the start may not be the right approach. But then secondly, on the managed care side, you've got to consider the formulary of the member or the patient that you're treating.
So here's the dilemma. We now have very powerful medicines which really have the same glycemic benefit for people who are fairly high in blood sugar as insulin. The SGLT2 inhibitors, the GLP-1 receptor agonists. So there are large head-to-head trials which look at, let's say, insulin glargine versus a GLP-1 drug, showing that you get less weight gain, less hypoglycemia, and equivalent or even better glycemic control with GLP-1s as compared to insulin glargine. Quite an impressive outcome, yet many managed care formularies will actually tell us that before using the GLP-1 drug, you have to do this and this and this. So steps that have no real medical basis other than cost consideration. And cost is important, but we have to think that the acquisition cost of the drug is only a part, and what really is expensive is the outcome. So sulfonylureas are widely used, yet there are these managed care databases that have been interrogated, not so much in the United States yet, although that's happening, but also in Europe, in the United Kingdom, and suggesting that individuals receiving, who are on metformin, who then receive a sulfonylurea, have higher mortality, higher cardiovascular disease outcome rates than individuals who have a DPP-4 inhibitor added. Similar study recently came out from a United States Veterans Administration database showing that thiazolidinediones actually, again, lead to better outcome than sulfonylureas when added to metformin. So we're starting to get this data, and yet it hasn't gotten to the formulary level, and it has to, because that will be so important in partnering with managed care in helping physicians to appropriately treat their patients.
John, any comment on the formulary piece?
Am I putting you on the spot?
No, I was just going to say, at WellCare, I can't speak for all of the managed care companies, but at WellCare, we do make an attempt to make the most cost-effective agent in the different classes available to our members. And where there's justification to say there's an exclusion and you need to take an alternate path, with the documentation, we've had no issues with approving that. So again, the important thing is the medications are tools, And when you're operating in the government-sponsored space, you want to make sure that you're stewards of the state and the federal government's money, and we're using that wisely to make available to our members the most cost-effective agents.
I'm moving all my patients to WellCare immediately.
Well, and I don't think you can lay this entirely at the feet of the managed care organizations and the insurance companies. Some of these medications are priced in ways that don't make sense. I mean, look at how much insulin has gone up over the last few years, and not just the name brands, but even the older NPH, the mixed insulins have gone up over the last few years. It doesn't make sense.
Yeah. Well, we've seen that with the PCKS9s, right, as well, in terms of pricing, and there's some therapeutic value, but for particular patients. And so navigating that area in terms of formulary, I know it's been a big area of discussion.
Yeah, and again, although none of us want to admit it, there are some clinicians that start with the agents they were trained with, or which may not be the most cost effective. And so the managed care steps in to say, let's make sure that there's a methodical method, that there's a step approach, and where there are exclusions or medication that's inappropriate for a patient, make that information available to the health plan, and you shouldn't have a problem getting it approved.
Although, excuse me, as I was going to say, as Zach said a moment ago, that sometimes we don't consider the total cost. You know, the total cost of sulfonylurea is probably far higher than the $4 at Walmart reflects. It is how much is the cost of the hospitalization that results from the hypoglycemia, or the hip repair because you got hypoglycemic, you fell and broke your hip, and now you need an expensive orthopedic procedure. So I think sometimes, and I know that it's difficult because one who may be on WellCare this year may be on some other plan the next year.
So downstream, the managed care company may not benefit from the investment of having given them more expensive.
Think about that with pre-Medicare and Medicare as well, right? I mean, if we get a handle on the population and do a bit of prevention, that can impact the Medicare program down the road. Bob, were you gonna?
Sorry, Bob.
Yeah, no. I think there's another opportunity that as thought leaders, I think the endocrinology community could be more engaged with managed care in terms of driving formulary decisions and giving our input, because I think I know that typically there'll be an endocrinologist on a formulary committee, but they're often not the sort of the most knowledgeable or the thought leaders that are considered in the endocrinology community. And so a little bit is on us to be able to be more involved and be able to help educate, because I think everyone's trying to do the best they can with the information they have, and we often have information that may not be available to everybody else, and be able to frame it in a different way.
And you're exactly right. Like at WellCare, at most managed care companies, we have a pharmacy and therapeutics committee, and we look at medications. Back to your point of how soon these medications are available on the formulary, well, all of this is based on the evidence. And what we're finding out is that in diabetes management, it's an evolving, dynamic environment. I mean, in the last 25 years, we've expanded the category of oral anti-diabetic agents by more than 10 individual categories. And so therefore, the managed care community has to keep up with that information. So it's an evolving process.
Right. So the utterly fascinating thing is that over the past 6 months, we've learned of 3 different types of diabetes medicines that actually are associated with reduction in cardiovascular outcomes. And that's going to have to be integrated into, it's a sea change. It's going to have to be integrated into how we treat particularly people with CVD, but also all people with diabetes whose risk of cardiovascular outcome is, if not quite at the level of a person who's already had a heart attack or stroke, approaches that level.